Hello, my name is Angela Craig, and I am a clinical nurse specialist and advanced practice nurse, and I'm a medical science liaison with Baxter Medical Affairs. We are going to talk today about hemodynamic monitoring and give you hopefully a good review on how to understand hemodynamic monitoring. As far as my disclosures, I am currently a Baxter employee as a medical science liaison. So I speak to the science and the evidence of stroke volume guided care and fluid management and hemodynamic monitoring. And I am still PRN at a hospital, Cookeville Regional Medical Center, as a clinical nurse specialist. I'm an independent consultant, and I am, as far as non-financial, I am on the Sepsis Alliance Advisory Board. As far as continuing education for nurses, this activity has been approved for 1 contact hour for nurses. A link to obtain your certificate will be available at the end of the presentation. Below you will see the accreditation statement, and support for this activity has been provided by Baxter. Our learning objectives today are to review the following variables and how they can bring value to patient monitoring. We are going to look at stroke volume and stroke volume index, cardiac output and cardiac index, total peripheral resistance and total peripheral resistance index, and we are going to use a case study approach to determine interventions to better care for a patient. And then we're also going to be reviewing the pathophysiology of what happens during hypotension. We are going to start out with a case study. I think case studies really help us to start thinking about how hemodynamic monitoring may help our patient population. So we have a 60-year-old female patient who's 5'4", 95 kilograms. They arrived to the emergency room with an infected leg. Now, this patient states that a dog bit her about a week ago. She thought she could fight off the infection by soaking her leg 3 times a day and putting antibiotic ointment on the wound. The area does appear reddened and inflamed. It does have green drainage oozing from the wound, and a foul odor is noted to the leg as well. So the patient is started on the sepsis bundle in the emergency department and connected to the non-invasive hemodynamic monitoring in the emergency room so that fluid can be individualized to meet the patient's needs. So as we think about hemodynamic monitoring, and we think about even in the early stages of a patient who comes into the emergency room, how those numbers can really help us to treat these patients individually and really try to individualize the care for the patient. I wanted to share with you this study that came out in the Lancet in 1944. And there were 7 male subjects, and they bled 7 male subjects. They took a liter of blood off of them. And what they found was that the blood pressure maintained until the patients passed out. Now, these patients obviously signed up for this. This was a study. They weren't really patients. They were male subjects who were in med school, I believe. And what they found was that blood pressure maintained. So let's think about that. Why does blood pressure maintain in a patient who is losing blood? Well, what happens to our patients? What happens to us when something like that happens? What happens to our blood vessels? They start to constrict, right? So our blood vessels are constricting. When our blood vessels constrict, that's trying to help maintain blood pressure to keep organs perfused. Now, the challenge with that is if you're just looking at blood pressure, that patient may look fine when they're not fine, right? Because compensatory mechanisms work to where we can maintain pressures, right, for a period of time until we're not okay. For instance, when these gentlemen passed out. But since we have this constriction, what's happening is our total peripheral resistance, which is a surrogate for systemic vascular resistance, that's basically increasing, and you'll see that on your non-invasive hemodynamic monitor. But the other thing you'll see is this cardiac output take a deep drop. Now notice on the mean arterial pressure or the blood pressure, you can see it really goes down just a little bit, but it stabilizes until boom, it drops drastically, and these gentlemen passed out. So I want to mention that to you because really we talk about, everybody looks at blood pressure, right? And yes, we need to look at pressure, but remember it's just pressure, not just pressure, but it's pressure, right? Is it flow though? And no, that's not, pressure does not equate to flow. So when we think about cardiac output, this is a better measure of perfusion. When you think about cardiac output, heart rate times stroke volume, that stroke volume is going to be where we can measure our patients and assess them. We'll more quickly know if they're declining. So we're going to talk through this whole process as we go through this slide deck. Now, I love this slide because I think it really shows you the importance of not just looking at traditional fluid monitoring, right? So notice this is very similar to what we just discussed in the previous slide. But you look here, your patient is losing blood, and patients can lose 25 to 30% of their blood volume before you see changes in mean arterial pressure, right? So notice what happens, like we discussed first. The SVR or TPR increases drastically. And why is that? We've talked about that. We are constricting. And then notice that cardiac output begins to drop very rapidly. And you see here that that mean arterial pressure maintains for quite some time. So we don't want to wait for the patient to lose that much of their blood volume, right, by just looking at mean arterial pressure. Now, how can you know that? How can you know that the patient is not doing as well if you don't have them connected to hemodynamic monitoring? You're just not going to know cardiac output, you're not going to know stroke volume, and you're not going to know TPR or SVR. Now, we know that physical exam findings like urine output, CVP, and or blood pressure abnormalities, those are late indicators. They may not reveal changes in cardiac output or in impaired tissue oxygenation. So this is where hemodynamic monitoring comes in to give us that bigger picture. Now let's look at some data that really supports the individualized care of all of our patients. So why is IV fluid so important? Well, when you think about fluids, we have to remember that fluids are not benign, right? Fluid is a drug, and I think we need to remember that. And if we think about, I like to compare it to like the Goldilocks principle. We don't want too much. If we have too much, we end up with tissue edema, organ failure, increased ICU ventilator days, increased mortality. If we have too little, then we end up with tissue hypoperfusion, where patients are hypovolemic, organ failure, insufficient perfusion, right? But we want just the right amount, and that just the right amount is where we have that optimal fluid, right? Right in the middle. And when we think about that, how can we know that? Well, I'm going to share with you some evidence and talk with you about stroke volume guided care so that you can get just the right amount for each patient, not too much and not too little. So sepsis is near and dear to my heart. And I have chaired a sepsis team for years at my previous hospital. And I want to just share with you, back in 2016, the guidelines came out for sepsis, and it talked about this exact thing that you're looking at using dynamic measures to guide fluid resuscitation over physical examination or static parameters alone, encouraging us to use a stroke volume measure. So why dynamic measures? Well, we know based on evidence that only 50% of patients are fluid responsive. So what does that mean? That means that only 50% of the patients may benefit from additional fluid resuscitation, And 50% of the patients won't benefit from additional fluid resuscitation. So this is where dynamic assessments come in. We need to know if our patient will respond positively to IV fluid or not. So there are two ways to do this. You can do a passive leg raise, which I'm going to talk to you about in just a second on the next slides, or you can do a fluid bolus. Now, the idea of this fluid bolus is not necessary for replacement. It's just basically to see and assess if that patient's heart can accept that fluid that we give them, increase stroke volume by 10% or greater to help forward flow and improve perfusion. Okay, so notice what we need to do. If we're giving a 250 bolus, it needs to go in less than 5 minutes. None of this 999 on the pump, right? Put it on a pressure bag, get it in quick. We're testing that left ventricle and really working it to see if they're going to increase their stroke volume. Now, if you want to give 500 fluid bolus, if that's what your provider wants you to give, that's fine as well, but it needs to get in less than 10 minutes. So once again, you're going to need to put that on a pressure bag, okay? Now, the second way to do a dynamic assessment is to do a passive leg raise test. You're going to often hear this called a PLR, standing for passive leg raise, right? So PLR. And what we're doing is we're first of all starting with our patient in that semi-recumbent position, right? We're trying to get them as high as they can go, like around 45 degrees or so. And we're trying to kind of pull that fluid or that blood off of from the top part of their heart on down, so that when we lay them flat, we can really see with that blood flow coming back to their heart if they're truly going to be fluid responsive. So we're transferring blood from the legs and the abdominal compartment toward the heart. So notice we start in that semi-recumbent position, and then we do a passive leg raise, which means after you've gotten your baseline data, which is about 4 minutes or so, you lay the patient's head flat and you lift their legs passively. Do not let them help you with this because that could increase their heart rate, right? And we know that heart rate times stroke volume is cardiac output. We don't want that to be falsely elevated, or we just want to see where they're at passively. So we lift their legs and we keep their legs up for about 1 to 2 minutes. Then we reevaluate that stroke volume measure and determine, do they have a 10% or greater increase in stroke volume? Now, when we study or look at passive leg raises, I think it's important to know the evidence that goes with that. So this particular meta-analysis shows that out of 23 clinical trials, the PLR, that when it was used with the cardiac output / stroke volume to predict fluid responsiveness, the area under the curve was 95%. That is an incredibly high area under the curve. You can see their passive leg raising retains a high diagnostic performance in various clinical settings and patient groups. It's easy to do this procedure. Nurses can learn it, and it's very, very, very helpful. Now, what do we do with our results? Well, if we have a greater than or equal to 10% increase in stroke volume or stroke volume index, that's considered to be fluid responsive, which means additional fluid most likely will improve perfusion if they need better perfusion. I think it's important to remember that we are utilizing this on patients who are hypoperfused or hypotensive. I could do a passive leg raise on many of you and you would be volume responsive. Does that mean that I need to put an IV in you and fluid resuscitate you? No, it doesn't. But if you are hypotensive or hypoperfused, then absolutely fluid may be a good choice. So we're going to use this data along with your patient assessments and give fluid to improve perfusion if that's appropriate. Now, if the stroke volume index or stroke volume is less than 10% with that passive leg raise, your patient is not fluid responsive. So additional fluid is unlikely to improve perfusion. So we're going to look at things like cardiac index, TPRI, to see if vasopressors or inotropic support are needed. So I think a very important thing to remember is that fluid responsiveness does not mean your patient needs fluid, right? So everybody, remember that. Fluid responsiveness does not mean your patient needs fluid. However, if they're hypotensive or hypoperfused, then they may very well benefit from fluid if that patient is fluid responsive. One of the best studies that I'd like to share with you in regards to a randomized control trial that's looking at this was the FRESH study. The FRESH trial, it was published in Chest in 2020, and it was fluid response evaluation in sepsis, hypotension, and shock, and it was a randomized control trial. And this is the algorithm for the FRESH trial. And basically they looked at, I'm going to just kind of reiterate, there's a lot of smaller words on that slide, but they looked at patients who are hypotensive or hypoperfused, and they had to, a clinical decision was made to treat the patient with either fluid or vasoactive medication. And that could have been related to different hypoperfusion characteristics, low blood pressure, low urine output, etc. Now, what they did was then they did a passive leg raise to determine if their patient was fluid responsive. And if it went to the left side where you had less than 10% change in stroke volume, then they would move straight to pressors, right? They wouldn't do the fluid because they know that the patient was not fluid responsive. Now let's talk for a second about fluid responsive. What are we looking at with fluid responsiveness? And maybe I should have said this on the previous slide, but we are looking to see if that heart can take that volume and help forward flow it to help improve perfusion. So we are looking at stroke volume, and stroke volume is what's in that left ventricle before it contracts. So do we increase stroke volume to help with perfusion and forward flow, or do we not? So in the right arm, as you're looking at that, they had greater than 10% stroke volume change, then they would go ahead and give a fluid bolus. If the patient remained hypotensive or hypoperfused, then they would go ahead and reassess a passive leg raise. Now, I think this is a really important point. You hear of hospitals having technology to where they can do passive leg raises and have hemodynamic monitoring, but they kind of do a one and done. They'll say, oh yeah, we put them on the monitor, but yesterday, and they were not fluid responsive. So then you're just kind of assuming they're not going to be volume responsive. But I want to encourage you, just like in this study, they had multiple reassessments. Your patients can change as you give different medications or as you give fluid. So I always think you go back to if they become hypotensive or hypoperfused, it's time for a reassessment, okay? And you can determine at your institution whether they're going to let you give fluid or not. My institution, we allow nurses to do a passive leg raise, and then we communicate with the provider to determine if they would like them to have fluid. Some institutions allow you to give fluid. It just depends on what your institution says. Now, the FRESH study endpoints were pretty impressive. You can see the fluid balance at 72 hours or ICU discharge. The treatment group, and the treatment group would be the stroke volume guided group versus the control group, which is the general care. Notice the difference in percentages. Less fluid balance in the treatment group, less renal replacement therapy in the treatment group, less mechanical ventilation in the treatment group, less length of stay for the ICU in the treatment group, and more patients were discharged home in the treatment group. Now, some of those are statistically significant and some aren't necessarily statistically significant, but I think they're very clinically significant. If you can decrease length of stay, that is wonderful in the ICU, as well as most of these patients would much prefer probably to go home to their own bed, right, versus to an extended care institution. Now, let's get right into the hemodynamic monitoring and talking about how we can utilize these variables to help us better care for our patients. When we think about cardiac output, like I mentioned earlier, that is heart rate times stroke volume. Stroke volume then moves into three dimensions or three areas: preload, afterload, and contractility. And so as we move forward, I'm going to talk through the numbers and what not just the numbers, but what these elements that we're going to look at preload, elements that we'll look at for contractility, and elements we'll look at for an afterload assessment. So let's start with the three levers of perfusion and explain those. We know it's all about perfusion, right? We talked about pressure, but we also talked about pressure does not equate to flow. So pressure is something we're going to look at, but we also want to identify flow. Heart rate times stroke volume is cardiac output. So we want to look at that cardiac output. We want to look at that stroke volume. So when we think about preload, I want you to think about stroke volume and think V for volume, okay? V for volume. Normal stroke volume is 60 to 100 mils per beat. Think normal heart rate. That should help you. So I want you to say this with me. You may think, people may say, what are they talking about as you're listening to this video, right? But that's okay. Talk out loud. Let's learn it together. So stroke volume, normal stroke volume is 60 to 100. Let's say it together. Normal stroke volume is 60 to 100. So hopefully you can remember that. Remember, in order to determine if a patient is fluid responsive, you need to do a dynamic assessment to determine if they're fluid responsive. Okay, so let's say we do a preload assessment, we do a fluid volume assessment, and the patient is not fluid responsive, but they still have a low stroke volume. So what are we going to do? Well, fluid clearly is not going to be the answer for them right at this moment. So let's look at our next levers. Let's look at afterload. How are they with their TPR and their TPRI? Remember, we're looking at how constricted or dilated this patient is. Think R for resistance. Now, TPR normal is 800 to 1200. Let's say this together. Normal TPR is 800 to 1200. Let's say it again. Normal TPR is 800 to 1200. Excellent. So if it's higher than 1200, they're more constricted. Trying to find my place here where you can see that. If it's lower than 800, they're more dilated, right? The vessels. All right, so that is our afterload indicator. Remember, the lower the number vasodilated, the higher the number vasoconstricted. Now, let's say that patient we just talked about that was not volume responsive has a very low TPR and TPRI. So they're dilated, right? Do they need to be squeezed? Maybe so. If they're not fluid responsive, we can't give them fluid. And if they're hypotensive and they're really dilated, we're probably going to have to add a pressor. Do you see how this is working? And we'll kind of go through this in a case study too momentarily. And then we have that contractility lever. Cardiac output, cardiac index. How is that heart functioning? Think C for contractility. Normal cardiac output is 4 to 8 liters per minute. Now remember, your indexed numbers, you guys, are those numbers that are more specific to your patient's height and weight, right? It's based on their height and weight. So you're going to make sure you have height and weight in there so that you know what their index numbers are. And so it's more specific to their body habitus, right? Now, if it's low, if cardiac index and cardiac output is low, you want to ask the question, why is it low? Because your cardiac output index can be low because your patient might need volume. But if we know that we've already done an assessment, a preload assessment, and we cannot add volume because they're not fluid responsive, then do they need something different? Is their stroke volume still low? It very well could be. And let's look at their cardiac index and output. If that is low, maybe they need something to help with that contractility. Now, another question I like to ask when I start looking at seeing low cardiac indexes and outputs, I wonder what their ejection fraction is. So pull that echo result out and let's look at how well their heart is contracting, okay? Now, let's start with our preload assessment again. I know I've already kind of gone through the 3 levers, but I want us to make sure we really understand that. Now, when we think about preload and how we currently assess preload, you can tell here that the volume status is something that we kind of look at, right? Some people use CVP. However, we just aren't placing the central lines like we used to, right? We're all trying to decrease our CLABSIs, so we're just not placing as many central lines. Now, some patients need them and have them, and so connect it if you like. Now, then it says it's unreliable, and why I want to mention that. I don't know if unreliable is the best word, but it's only about 50% of the time that it's like a flip of a coin that number really necessarily makes sense to your patient. I think a lot of us, if we're using that as a fluid responsive measure, that's really not a good fluid responsive measure. Sometimes we're giving fluid and that CVP doesn't go up, and that's what I'm talking about. Or you're not giving fluid and it's, you know, it goes up and down, and it doesn't make sense based on what you're looking at it for when a fluid responsive situation. Now, with wedge pressures or PAOP, pulmonary artery occlusion pressures, we just don't have as many Swan-Ganz catheters anymore, right? We're not always placing a right atrial pressure monitoring system. Now, some departments use a lot of Swan, so this may be more helpful for you. However, I know the ICU I'm from, we float a Swan once in a blue moon, right? The other thing I want to mention is stroke volume variation and pulse pressure variation. Sometimes people utilize that, but there are a lot of limitations in the ICU, so you really need to know what those limitations are. And there are things like if your patient is a spontaneous breather, if they're not on 8 mils per kg of tidal volume, you're going to have less sensitivity and specificity to that, to utilizing that. So I really don't, so we're not going to look at that as much. We will assess urinary output, but like we've talked before, that may be a late indicator. So something that's very reliable is stroke volume and stroke volume index. So just like we talked about with the perfusion levers, looking at stroke volume and stroke volume index can be very, very helpful. Now, when we look at this preload assessment, we're looking at stroke volume. Like I mentioned, blood is ejected from that left ventricle per beat. That is what stroke volume is. And normal is, let's say it together, 60 to 100 mils per beat. And then you have your stroke volume index. Stroke volume divided by body surface area. That is a normal is 35 to 37. So our next assessment is the contractility assessment. And so we are really looking how effectively is that heart pumping, right? So just like I mentioned previously when we were talking about the levers, how well is that patient's ejection fraction? Looking at the echo is very important. Now, what we're going to look at in a contractility assessment we are going to look at stroke volume. So that's that cardiac times 1,000 divided by heart rate. So like I mentioned, that blood that's ejected from the left ventricle per beat, we are looking at that in contractility as well. So when we aren't fluid responsive, we don't have that increase in stroke volume, then we need to think about maybe this is a contractility problem, right? With a low stroke volume or stroke volume index. And then we also will look at cardiac output, which is stroke volume times heart rate. And we're going to look to assess if that's low. Normal is 4 to 8 liters per minute, remember, and with our cardiac index, normal is 2.5 to 4. So we really want to look at those numbers as well as our stroke volume index to determine if there's poor contractility. Now, if there's poor contractility, then the provider may want to start an inotrope. It just depends on the scenario and what's going on with the patient. Next, we have our afterload assessment. I call that the squeeze. So your afterload is more of the squeeze, right? When we think about the resistance that heart has to pump against. And so here's what we think about total peripheral resistance and total peripheral resistance index, okay? TPR and TPRI. Now, TPR is a clinical indicator of afterload. It's that resistance to the ejection of blood during left ventricular contraction. Like we mentioned earlier, normal is 800 to 1200. Let's say it together, 800 to 1200. So you know if that number is lower, we're more dilated, and if that number is higher, we're more constricted, right? Excellent. Now let's get right to our case study, and here's where it gets good, guys, so hang in there. So back to our case study, just to remind everyone, this is the lady who came in with the nasty dog bite, and that area is reddened and inflamed, nasty smelling, and they were started on this sepsis bundle, which let's just review this 3-hour bundle, right? Just for kicks and giggles, because I love sepsis. I mean, I don't love what it does to people, but I love how early intervention can save lives. So we want to make sure that what do we need to do? We need to go ahead and speak it out, give IV fluids. It does say IV fluids if the patient's in a shock state. So 30 ml per kg is what the guidelines recommend. However, CMS, if you document that your patient is not fluid responsive with using a stroke volume or a cardiac output measurement, you will not be held accountable for the fluid requirement. Okay, I just wanted to share that with you. That's new from CMS, just an extra there. But we also need to think about getting that lactic acid, getting blood cultures ×2, and giving a broad spectrum antibiotic if it appears that the patient is infectious. Okay, so this patient was started on all that, and then in the emergency room, and they connected them to non-invasive hemodynamic monitoring. Good for that ED. Now you can see here that the patient did have all those things we mentioned, as well as the antibiotic was given, and the patient's temperature is elevated, 1015. You can see the blood pressure is low with the mean arterial pressure of 53. Heart rate's elevated at 125, and white blood cell count is elevated at 20,000. Lactate level is 6. BUN is 30, creatinine's elevated at 2.2, and the procalcitonin is elevated at 4. So this patient definitely is in septic shock criteria, even though she's talking to us. She's not ventilated, but she has known or suspected infection. She has multiple surge criteria. Her temperature's elevated, her heart rate's elevated, her white count's elevated. She has multiple organs down, blood pressure's low, so cardiac's down, lactate's elevated, so metabolic's down, creatinine's elevated, so renal's down. So as you can see, there's already 3 organs down. So she is definitely in septic shock because she's hypotensive, and they've already given her some fluid. She's still hypotensive, and her lactate's high. Okay. So our first question always for our patients, is this patient hypotensive or hypoperfused? And this patient definitely is hypotensive. You can see that mean arterial pressure is 53. Let's look at our other variables from the non-invasive hemodynamic monitor. We have a stroke volume that's 45. What did we say normal stroke volume is? 60 to 100, right? Yes. So we are low, right? Our TPR is 671. What is normal TPR? Remember, 800 to 1200. So we are low. So are we dilated? Are we dilated or are we constricted? We are more dilated, right? And then you can see that cardiac index is 2.7 and cardiac output is 5.6. So I think since this patient is hypotensive or hypoperfused, they deserve an assessment. So whether you determine to do a passive leg raise or a fluid bolus, as long as it's done appropriately, that can be your hospital's preference. I personally like passive leg raises. I call it the poor man's fluid bolus. It doesn't cost anything extra. And if they have lower extremities, obviously if they don't, that's not going to be the choice for them. But we're able to do that test. And if for some reason they are not, as you do the passive leg raise, they become tachycardic, tachypnic, just lift their head and lower their legs and let gravity pull that back away. When we give fluid, then we have, and if they don't respond well, then we have to remove it somehow. So that's what I kind of like about the passive leg raise. And then it's got great sensitivity and specificity when you're using it with stroke volume. All right, so we do the passive leg raise, and I've done the math for you, but what you can see here is that the heart rate is still elevated. MAP is still low, but the stroke volume went up from 45 to 47. But when you do the math, it does not equate to 10% or greater, right? So is this patient volume responsive? Yes or no? Shout it out. Okay. Hopefully you said no, because it was not 10% or greater, right? So they are not fluid responsive. So will fluid be the answer for this patient? No, right? Based on what their heart can take and forward flow to help improve perfusion, fluid's not the answer for this patient right now. So based on our clinical findings, what should we consider next? Do we want to give a vasopressor and kind of tighten them up a little bit? Do we want to give them an inotrope to help with their contractility? Do we want to give more IV fluid, or do we want to give a vasodilator? Well, we know, let's start with preload. We know that this patient has a low stroke volume, right? So it would definitely warrant the fact that we should do a passive leg raise. We did a passive leg raise, and our delta stroke volume change was only an increase in 4.4%. So we know that fluid's not the answer. So we're going to mark off a C, right? We're not going to give more fluid. However, now we know that our stroke volume is still low and we have a low TPR. So we're dilated and hypotensive, but yet our cardiac index and output still looks okay. So most likely we're not in that contractility part yet, that where they need help with contractility. So I hope you all, and then do we want to give a vasodilator to somebody with a MAP of 55 and 53? So hopefully you chose, here we go. So after the drum roll, hopefully you chose to give a vasopressor, because we want to tighten them up a bit and hopefully increase their blood pressure, right? Hopefully you got that right. So now let's move on. So we started that norepinephrine at 5 mics per minute, and we increased that over the next hour to our institution's max. Okay, and I don't know if you have an institution max, but I just wanted to put that out there because most likely many of us do have institution max. So we know that we're at the max, and let's look at our numbers. So we have a heart rate that's gone down a bit, which is good, and our temperature's gone down a bit. We did give some Tylenol to that patient. And then you can see the MAP is up to 60, but we still want our patients to be at least 65 mean arterial pressure, right? Stroke volume is low at 49. We know that's low, but look what happened to our TPR. Well, would we have expected that to happen? Yeah, we started that patient on norepinephrine, right? So we have tightened them up a bit. And so you're going to see there that number should increase as you up-titrate your vasopressors. Now, remember, as you up-titrate your vasopressors and you constrict a little bit more, it's going to be harder for that heart to pump against that at times. So if the patient doesn't have a good pump, we've really got to be watching that cardiac output and that cardiac index as well, okay? All right, so our next question is this patient still hypotensive or hypoperfused? And the answer would be yes. Hopefully you said yes. Our mean arterial pressure is only 60, and this patient's stroke volume is still very low. So what does this patient deserve? A dynamic assessment. So we're going to do a dynamic assessment, whether that's a PLR or a bolus. And here's what happens. So we have norepinephrine going. We are still maxed at our institution max for norepinephrine. And we just did a passive leg raise, and our stroke volume increased by 6.1%. So let's go to the question. Based on our clinical information presented, what should we consider next? Now, if we're at institutional max, do we want to still increase above that? And I guess that's going to go back to what your guidelines are at your institution. Do we want to add another vasopressor, which would be for sepsis, the suggested next one would be vasopressin? Do we need to give an inotrope, something to help with contractility? Do we need to give more IV fluid? Hello, we weren't fluid responsive, so hopefully you are not even considering that one. Or do we need to give a vasodilator? And I'm just really hoping you didn't choose vasodilator. This patient has already been struggling with vasodilation, but also has a low mean arterial pressure. All right, so based on that information, we are going to add another pressor. I hope you got that answer, and we're going to add vasopressin, okay? So as we, just to mention the order of pressors that were started, norepinephrine was started, we're at institution max. Vasopressin is at a set dose, okay? And let's check and see how the patient does with that. So the pressors continued. Blood pressure did improve for the next hour. So you got an hour, right, without having to do a PLR. MAP was greater than 65, and TPR improved as well. And the patient's lactate did decrease down to 4, which is still high, right? But it's better than it had been. But it's been an hour, and all of a sudden you notice that that cardiac index has dropped, but you noticed before that the stroke volume dropped. So notice we have a normal mean arterial pressure, but we have a very low stroke volume, right? Only 35 mils. Notice that TPR. Now we said normal was 800 to 1200, and now we're at 1231. So we're pretty constricted, right? And notice what that's doing to our ability for the heart to pump effectively. And so we have to take that into consideration, and we also need to know what that patient's heart function is. So notice the cardiac index is down to 1.9. I hope that's given some of you heartburn, right? Because that's not good. And the low stroke volume is not good. And I think I see what's happened here in our good efforts to try to improve perfusion by increasing blood pressure. Sometimes we have some other effects, right? So as we constrict, it causes difficulty for that heart to pump. All right, but our question is this patient hypotensive or hypoperfused? And my answer would be yes, right? Because even though their mean arterial pressure is normal, it's probably because we have so many pressors on board, but their cardiac index is less than 2. So that's a problem, and we need to focus on that. So based on our that assessment, they deserve a dynamic assessment, right? So we're going to do another passive leg raise or a fluid bolus, whichever is the preference of your institution. And our stroke volume change came to 8.6% increase. All right. So based on that, is this patient fluid responsive? I hope you are saying a hearty no, right? It's not 10% or greater. So let's look at our question here. Based on the clinical information presented, what should we consider next? So I think at this point, we need to think through our options, right? We have a normotensive patient, but still a very low stroke volume, a high TPR, and a low cardiac index. So are we going to increase norepinephrine? No, because our pressure, is fine. We're not going to add another vasopressor, but would we want to give them fluid? No. Would we want to give them a vasodilator? No, not at this point. So maybe something to help with their contractility. So we are going to give an inotrope. Very good. I hope you chose that. So now we started dobutamine, and we have norepinephrine, vasopressin, and dobutamine all going on this patient. And we find that pre-inotrope, you can see the numbers there. 1 hour post-inotrope, look at that cardiac index, how it improved, as well as it improved that stroke volume. And notice what it did to that TPR. It really helped to normalize that out. So you have better heart function, and then it's really going to help decrease that constriction and also help improve your cardiac index and output. So good work. And we did great for 3 hours. Your patient was doing well. And all of a sudden you noticed first your stroke volume. It went from 50 to 42. But then you also noticed that mean arterial pressure came down as well to 61. and you see that low stroke volume. TPR is normal, and cardiac index is 2.2, so it's better than what it had been, and we're still on those current 3 infusions. So our question is this patient hypotensive or hypoperfused? And the answer is yes, right? Their mean arterial pressure is only 61 and their stroke volume's low again. So they have earned themselves another dynamic assessment, right? So we're going to do that. And lo and behold, the patient is now fluid responsive. After all this time, they are 14.3% fluid responsive. So is this patient going to need fluid? Well, let's look at the question. So based on our clinical information presented, what should we consider next? We don't need to increase the norepinephrine yet, right? We only are at a 62 MAP, but remember, we are fluid responsive now. So let's try to give fluid a chance to see if it will improve our blood pressure as well. So we are going to give some more IV fluid. And notice after a 500 ml bolus was given, you can see that mean arterial pressure is now normalized at 66, and that stroke volume is up to 52. TPR is normalized at 873, and that cardiac index is even better than it had been, okay, up to 2.6. So what would we like to do at this moment? Now, I want you to pause for a second and think about your patient. They've had multiple improvements at this moment. And do we need to give them more fluid? Back in the day, we used to say that we would give fluid until they quit having a positive fluid responsive test. But that's not really the case now. Many people live kind of on that lower portion of their Frank-Starling curve. So I think you're looking at perfusion indicators for that patient. In this situation, they are normotensive now. They have a normal cardiac index. They have a normal TPR, but their stroke volume is a little bit low. If you felt so inclined, you could do another passive leg raise and see if they might need a little more fluid. But honestly, I think their parameters look good enough to where you could probably hold tight. Okay, but that's going to be up to your physician to determine, you know, what they want to do. And if you have a nurse-driven protocol where you can just do another passive leg raise, then ask the provider, say, hey, they just did have another 10% increase in stroke volume. Do you want me to give another 500 or whatever? But the idea is that you're using stroke volume to guide and personalize your care of your patient. Now, there are multiple references here on this reference list that you are more than welcome to reference and look at. There's a lot of data out there on this. And I also want to leave with you my email address, because if anybody would like to email me with questions or concerns or just talk about a patient scenario, I'm happy to take your email. My email address is Angela_Craig@Baxter.com. And I really hope this has been helpful for you to really review those variables and understand how to utilize them in a systemic way, right? I shouldn't say systemic, systematic way, to where we can make a difference in the life of our patient. I hope you've enjoyed it. It's been great being with you. Take care. Happy hemodynamicing. As far as continuing education for nurses, this educational activity is approved for 1 contact hour. To obtain CE credits, go to www.saxtesting.com/RB, and you will need to register at the site. You will complete the evaluation, the post-test, and upon successful completion, you will be able to print your certificate of completion. Support for this activity has been provided by Baxter.